أهلا بيكم. This lecture we will start studying the ear. So let's begin. The ear is the organ for hearing and equilibrium. Never forget this, of course. And is divided into external ear, middle ear, and internal ear. External, middle, and internal. Okay? The external ear extends from the ear pinna or the auricle medially until you hit the tympanic membrane through the external acoustic meatus. So this is the external ear. The auricle is very prominent, of course, feature outside. It's anchored in the edges of the external acoustic meatus, the bony part, by this cartilaginous piece. It's all from elastic cartilage except for the lower part, which is devoid of cartilage, just of fibrofatty tissue, the ear lobule. This is called the lobule. And if you look at the structure or the shape of the ear pinna, you'll find this prominent ridge on the outside. It's called the helix. Another one in front of it is called the antihelix, and it divides into superior and inferior corneo. Now, look at these two projections. This one is the tragus, and this one is the antitragus on the antihelix. And there's a notch between them. It's called the intertragic notch. Now you see this depression inside the ear pinna. This is the concha, and the floor of the concha is the beginning of the external acoustic meatus, which you can see here. The external acoustic meatus, it has, we will talk about it soon now. Okay, now for the ear pinna, any muscles involved? Yes, there are intrinsic muscles connecting the cartilages together, and extrinsic muscles. We studied them with the face muscles, facial muscles, the auricularis anterior, superior, and posterior. Remember those? And they are supplied by the facial nerve, the front by the temporal branch, and the back by the posterior auricular branch. Okay? These are, of course, they are rudimentary muscles, so nothing much to say about them. The innervation of the auricle is important, and it's a good subject for multiple choice questions. Now, the outer surface is the anterior surface, and this one is the posterior surface, the cranial surface, the one that faces the skull. The anterior surface from the front is taken up by the auriculotemporal nerve, which you can see branches here from the auriculotemporal. And much of the anterior surface and the posterior-inferior surface, means the lobule from both sides, it will be taken by the great auricular nerve. See, this is the great auricular nerve. We talked about it, of course, in the posterior triangle, and the cervical plexus. It carries C2 for the anterior surface and posterior-inferior surface of the auricle. Now we are lifted up with the posterior-superior surface. It's taken up by this nerve, which is the occipital nerve. Of course, you remember this from the cervical plexus. So we have the auriculotemporal, we have the great auricular, and we have the lesser occipital. Now there are branches, tympanic branches, from the vagus and the facial, also supply by the auricle, but the deep parts, and it may extend outside in the floor of the concha to supply it. And in this case, the person who has this distribution is liable to a neurogenic shock if he received a hit, a good hit on his ear, on his auricle. Okay, it will may produce a reflex called the vasovagal shock, in which the vagus will be hyperstimulated, and this will lead to depression of the circulation. Right? Okay, the vessels, of course, the nearby superficial temporal, the posterior auricular branch, the occipital, takes the upper part, all share in the supply of the auricle or the ear pinna, and the veins follow the arteries, of course. Lymph to the mastoid and parotid lymph nodes surrounding the auricle. The external acoustic meatus is the one it's the canal that starts from the floor of the concha till you hit the tympanic membrane. It's about 1 inch in length, wider laterally than medially, and it's lined by skin which is adherent actually to the periosteum of the bone, especially the bony part. Of course, adherent to the cartilaginous part as well. And this manifests with that whenever we have collection of tiny amount of pus, it produces a severe pain because the pus is peeling off the skin off the periosteum. The periosteum is very rich in nerve supply. So it's very painful, any lesion in the external meatus due to the adherent skin. The skin lining contains the modified sweat glands called the cerumen that secretes the earwax. The earwax as a protection repellent for insects and protection for the tympanic membrane inside. Okay, this is about the external acoustic meatus. We'll lift up with its direction. It runs anteromedially and superior, going superior, and then at the end it goes down a little. So if you need to examine it with an otoscope, you must pull the ear pinna upwards and backwards to straighten up the canal to be able to have a good look on the tympanic membrane. Pull the auricle upwards and backwards. The nerve supply of the canal, the antero-inferior part, see this is the bony part of the canal, formed the anterior and inferior parts by the tympanic plate of the temporal bone, the rest by the temporal bone. See that this is the antero-inferior wall of the bony part. It's supplied by the auriculotemporal nerve, while the posterior-inferior quadrant is supplied by the branches of vagus and the facial, but mostly taken up by the auriculotemporal nerve. Don't forget that. Okay, the tympanic membrane is a double membrane. Actually, it's lined by skin from the outside, thin skin, of course, and by a mucous membrane from the inside. It has a double embryology, and it separates the external ear from the middle ear. External ear from the middle, because it's the limit for the medial wall of the external acoustic meatus. It's connected to a fibrocartilaginous or a fibrous ring surrounding it called the annulus, and it's directed anterior and inferior, antero-inferior. Okay, so if you look at it, you will see it directed forwards and downwards, antero-inferior. Okay, when you take a look at it, it's concave, so something must be pulling on it from the inside, yes, which is the handle of malleus, and the tip of the handle of malleus produces what's so-called the umbo, which is the peak of the concavity of the tympanic membrane. And if you go up with the handle of malleus, the membrane will be attached along the handle until you reach the lateral process of the malleus. Then the membrane is folded into two folds, anterior and posterior malleolar folds. Now, between these folds, the membrane is flaccid, lax. So this is called the pars flaccida. While, see, the rest of the membrane is taut by the handle of malleus and the muscle pulling on it, which is the tensor tympani. So this is called the pars tensa. So you have the pars tensa and the pars flaccida between the anterior and posterior malleolar folds. And because of this arrangements and the handle of malleus pulling on the membrane, when you eliminate with an otoscope, you will see a cone of light anteroinferiorly, in this direction, cone of light. The cone of light is of significance for the ENT specialists, since the changes of cone of light reflects what's happening, especially in the middle ear, what's behind the membrane, like like otitis media, for example. Okay, the inflammation of the middle ear is called otitis media. Inflammation of the external ear called otitis externa. Otitis externa, like the one you see in swimmers. Okay, and it's very painful, as we said, because of the adherent skin. Now, back to the tympanic membrane. See, this is the inner side of the tympanic membrane. The handle of malleus is pulling on it. See how it pulls on it because of the attachment of this muscle, which is called the tensor tympani. The nerve supply, most of it is by the auriculotemporal, the outer side we're talking about now, auriculotemporal, and the posterior inferior quadrant is by the facial and vagus, while from the inside it belongs to the middle ear now, so it's supplied by the same structure that supplies the middle ear mucosa, which is the tympanic plexus. The tympanic plexus formed by the glossopharyngeal nerve. So from the inside, it's the glossopharyngeal nerve. From the outside is the auriculotemporal nerve, vagus, and facial nerves. Okay. This is regarding the tympanic membrane. It's all easy. There's structures and unique structures as well. Now, once you pass the tympanic membrane, you are in the middle ear. The middle ear is a cubical slit between the inside of the tympanic membrane laterally and the lateral wall of the inner ear medially. This wall which bulges towards the inside, this is called the promontory. It's produced by the basal turn of the internal ear. So this is the cavity of the middle ear, actually. It's a slit-like structure. It communicates anteriorly with the nasopharynx through the eustachian tube or the pharyngotympanic tube, and posteriorly with the mastoid air cells through the aditus, and we will study this. This is the opening for the tube in the anterior wall of the middle ear. Now it's full of the three ossicles, the malleus, the incus, and the stapes. Malleus, incus, and the stapes here. The stapes. See, this is the malleus, this is the incus, but the stapes is not showing because it's towards us, towards the lateral side. Now we're looking on the medial, on the lateral wall of the middle ear from the inside. Yes, contains the ossicles, and the ossicles are there. They articulate with each other in synovial joints, plain synovial joints, and their function is to magnify the amplitude of the sound wave, the pressure wave that's reaching the tympanic membrane. We will talk about that. Okay, it has a roof, it has a floor, it has a medial and lateral wall, anterior and posterior walls. The roof is a piece of bone present in the anterior part of the petrous part of the temporal bone. It's called the tegmen. Tegmen means cover. Tegmen tympani. Tegmen tympani covers the middle ear. This is the roof. And the floor separates it from the bulb of the internal jugular vein. This is not the vein. This is the artery, a carotid artery, internal carotid, anteroinferior to the middle ear. But the bulb of the internal jugular vein is right underneath, and sometimes this thickened by mastoid air cells, the floor. Now, in the floor, from the medial side, medial border, penetrates the tympanic branch of glossopharyngeal in the floor, in the medial border of the floor. We will see this. In the lateral wall or membranous wall, it's the inside, simply the inside of the tympanic membrane. This is anterior, this is posterior. Towards me is medial, and this is the medial surface of the lateral wall. Now, the lateral wall is the inner side of the tympanic membrane with the malleus on it. And if you go up, see this space, the cave inside the bone. This is called the epitympanic recess. Epitympanic recess is continuous with the adductus that opens to the mastoid air cells on the lateral wall. This is on posterior wall. See, epitympanic recess, the recess to accommodate the head of malleus and the body of incus. The head of malleus articulating with the body of incus occupy the epitympanic recess, which is a feature of the lateral wall of the middle ear. It's called the membranous wall because it's simply mostly by the medial side of the tympanic membrane. Okay, the posterior wall, this is the posterior wall, this is anterior, this is the medial wall, and I'm standing on the inside of the lateral wall looking. This is posterior. You can see there's an opening upwards called the addutus that will lead you to the mastoid air cells. And mastoid air cells, by the way, they are not counted as paranasal air sinuses. Do you think why? Do you know why? Because it's not lined by respiratory epithelium. It's lined by simple mucosa. Okay? So the mastoid air cells are not part of the paranasal air sinuses. Back to the posterior wall, you will find the addutus upwards and downwards a pyramidal prominence, or the pyramid, that will give rise to a muscle. The pyramidal process is a feature of the posterior wall and gives origin to the stapedius muscle that goes forward and medially to insert in the neck of the stapes. See? This is the stapedius muscle arising from the pyramidal process on the posterior wall of the middle ear. What else you will find on the posterior wall? The chorda tympani branch piercing the wall and on its way to the lateral wall to cross the handle of malleus and pierce the anterior wall and descends down the chorda tympani, remember, to emerge from the petrotympanic fissure. It's coming from the posterior wall because the facial nerve descends around the posterior wall and then downwards. Okay, this is the posterior, or called what's so called the mastoid wall, because it's related to the mastoid air cells. The anterior wall, if you are looking at the anterior wall, you will find two holes. One for the semi-canal for the muscle, tensor tympani muscle, which is the superior opening. And at the edge of this opening is a process called the processus cochleariformis, or cochleariform process, that will, the tensor tympani will hook around this processus cochleariformis and goes to the lateral side towards me to insert into the handle of malleus. Okay, which you can see here because we removed the lateral wall and we are looking to the inside, to the medial wall of the middle ear. Okay, so you have this opening and processus cochleariformis. What else? Beneath it you'll find the opening for the eustachian tube, or the pharyngeotympanic tube. This is the posterior bony part of the pharyngeotympanic tube, and it will emerge later as cartilaginous part and open into the nasopharynx, as we studied with the pharynx lecture. Okay, so this is what you will find in the anterior wall. Anterior-inferior to this is the carotid canal, the internal carotid artery and its canal, and also we have the exit in the anterior in the anterior wall, the exit of the chorda tympani. So the entrance of the chorda tympani from the posterior wall and the exit from the anterior wall laterally. Okay? It's easy, not complicated, because every wall is unique in its features, so it's easy to remember and understand. Okay, let's proceed. The medial wall, which we are looking at right now, the first thing that draws attention is that it's a bulging wall. This is because of the basal turn of the cochlea. Beyond this wall is the basal turn of the cochlea of the inner ear. What else you will see? You will see two holes. This is the fenestra vestibuli, or fenestra ovale, or the oval window, and this is the fenestra cochleae, or the round window. Now the oval window will be plugged by the basal process of the or foot process of the stapes, while the round window will be covered by a membrane, and this membrane is called the secondary tympanic membrane, because the primary tympanic membrane is the lateral wall of the middle ear. This is the secondary tympanic membrane. So remember, the ovale, the superior one, is plugged by the stapes, has no membrane, and this one, the round window, is covered by a membrane. We will understand the significance of this when explaining the mechanism of hearing. Okay, another feature on the medial wall, two prominent protrusions, posterior superior to the stapes, or to the oval window. The first one is for the facial canal. See the facial canal on its way into the posterior wall and down. And the second one above it is for the lateral, the impression of the lateral semicircular canal, the lateral semicircular canal of the inner ear. So we have two elevations here, posterior superior to the ovale, fenestra ovale. The first one is the facial canal, and the second one above it is for the impression of the lateral semicircular canal. See, lateral semicircular canal making an impression on the medial wall. See that? This is the canal from the inside, of course. This is the impression of it from the inside. Okay, so again, the promontory. Now, what you see on the promontory, the mucosa is different. It has so many branches underneath. This is the tympanic plexus. The tympanic plexus produced by the tympanic branch of glossopharyngeal that pierced the floor and spread its branches over the promontory. This promontory, This plexus receives also from a branch from the internal carotid in the canal. Okay, sorry, not this one. In the canal, anteroinferior, internal carotid in the canal sends sympathetic from its plexus to join the plexus. So the plexus is formed primarily by the glossopharyngeal tympanic branch and sympathetic component from the plexus around the internal carotid artery. You will see also emerging from the plexus and going anteriorly through the bone is the lesser petrosal nerve. Of course, you know about the lesser petrosal nerve, which carries the preganglionic parasympathetic fibers to the otic ganglion. It will descend later through the foramen ovale. Okay. The pharyngotympanic tube, we said it starts in the anterior wall of the middle ear, and this is the posterior bony part. There is an anterior cartilaginous part C. It emerges right behind the foramen ovale and spinosum and goes anterior anteromedial direction. It pierces the pharyngobasilar fascia and raises the mucosa there. Remember the tubal elevations it produced in the nasopharynx. So it has an anterior cartilaginous part and a posterior bony part. Okay, its function is to equalize the pressure between the tight space, the middle ear space, and the external environment. Okay, that's why when it gets plugged, a negative pressure will build up here in the middle ear and it will suck on the tympanic membrane. You will feel it in your ears. And if it increased, the negative pressure increased, the suction would increase and pain start to elicit from your ears. Okay? All of us had this when during traveling by airplanes. So it equalizes pressure between the middle ear and the outside through the never closed nasopharynx. Okay? And of course, it has the muscles attached to it like the levator and tensor villi palatini. So whenever they contract, they pull on the cartilaginous part and drain the tube if something inside because it's lined by mucosa. Now, it takes blood supply from the surrounding ascending pharyngeal, middle meningeal, artery of pterygoid canals, all the arteries in this area. And the nerve supply mostly belongs to the middle ear mucosa, which is the tympanic plexus. The maxillary nerve may encroach on the anterior and anterior part of the mucosa to supply, because you know the mucosa of the nasopharynx is supplied by the pharyngeal branch of the maxillary nerve. Yes, this is all to be said about the Eustachian tube. This is a diagram for the middle ear. I thought it will explain much of the details. This is the anterior wall with the two openings, tensor, tympani, and the tube. And see the exit of the chorda tympani here. See the entrance of the branch from the internal carotid. See the exit through the anterior wall of the lesser petrosal nerve. This is the tympanic plexus. And this is the tympanic branch coming from the floor, spreading onto the medial wall. This is the facial canal exposed to expose the facial nerve. This is the stapedius muscle. See the facial supplying the stapedius and supplying and giving off the chorda tympani. The ear ossicles, they are three bony structures articulating together, and you see them here articulated. See, this is the malleus, this is the incus, and this is the stapes. The malleus has a handle that attaches to the medial wall of the tympanic membrane, has an anterior process, see that? It connects, it's attached to by a ligament to the anterior wall ligament. This is the lateral process of the malleus that's, marks the end of the attachment on the tympanic membrane and the start of the malleolar folds. We saw that on the inner side of the eardrum. This is the head and neck of malleus, the head articulating with the body of the incus. This is the body of the incus. The body of the incus that has a posterior process connected by a ligament to the posterior wall. Okay, so you have a ligament anterior, ligament posterior, and it has an arm, a limb that descends parallel to the handle of malleus and bends medially downwards to articulate with the head of stapes. See, this is the stapes. The stapes has a head, has a neck, and anterior posterior pillars, and the foot process or basal plate. This is the stapes. The basal plate fits into the foramen, the oval window in the medial wall of the middle ear. Okay, so these are the ossicles. Of course, the joints between them is synovial, plain synovial joints. And by the way, with old age, calcium starts to precipitate in tissues, and these gets, get rough, not as smooth as before with age. So there's difficulty in hearing. The hearing acuity declines. This is called the otosclerosis. Auto with an O, O-T-O, otosclerosis. It's a common development with age. Okay. Now, muscles associated with the ossicles. We have two muscles. The tensor tympani muscle that comes from its own tube, originates from its own tube, from the undersurface of the greater wing of sphenoid and from the cartilaginous part of the tube, goes backwards, and then around the cochleariform process, it turns laterally to insert into the handle of the malleus. And the nerve supply of the handle of malleus, of the tensor tympani, is the nerve to medial pterygoid. Remember this, I studied it in the infratemporal fossa. Okay, so it looks like this muscle will damp down any excess vibrations delivered to the eardrum to prevent injury to the eardrum. Okay, the same principle with the stapes. This is the beginning of the transport for the impulse of the mechanical impulse, and this is the end of the mechanical impulse here in the middle ear by the stapes, and there is a muscle, the stapedius, is attached to the inserted into the posterior end of the neck of stapes. See that coming from the posterior wall, from the pyramidal prominence. It's supplied by fascial. Note that the two muscles have different nerve supply. One from trigeminal and mandibular division, and one from the fascial. Reflects the importance of these muscles. This also, the stapedius, dampens the excess oscillations that reaches the stapes. Otherwise, it will fall off the oval window. And when this muscle gets paralyzed in a deep lesion for the facial nerve, for example, a state of hyperacusis develops, means the stapes oscillates with any vibration reaching, and there is a state of hyperacusis. Hears the voice loud. Okay, hears the sound loud, hyperacusis, and this is a sign to distinguish the level of injury of the facial nerve if you're investigating it. Okay. The vessels of the middle ear, the surrounding vessels from anterior tympanic of the maxillary to the occipital mastoid branch, branches from middle meningeal, ascending pharyngeal, the pterygoid canal, and the venous drainage follow the arteries, of course, to the pterygoid venous plexus and superior petrosal dural venous sinus. Of course, we will study the dural venous sinuses later with the cranial cavity. The innervation of the middle ear, actually, it's all the credit goes to the glossopharyngeal nerve, the tympanic branch. We talked about it before, that when the nerve is about to exit the skull, it sends back a tympanic branch in its all canaliculus, pierces the floor of the middle ear and spreads its branches over the promontory of them on the medial wall of the middle ear, joined by a sympathetic branch from the anteroinferior internal carotid artery plexus, and that's it. This is the tympanic plexus, and it gives away the lesser petrosal that carries the parasympathetic component through the glossopharyngeal nerve and destined to the otic ganglion after it descends from the foramen ovale. Of course, you know about this story. By the way, the nerve supply of the middle ear part that you see here includes everything, and except the muscles, of course. We are talking sensory supply, including the mastoid air cells, including the eustachian tube or the pharyngeotympanic tube. That would be all for this lecture, and thank you very much for watching.